what are the aims and objectives of treating or looking at failed back surgery syndrome? Well, it's the primordial deterrent for a spine surgeon in the process of achieving his holy grail. The analysis of surgical results in the form of an audit spanning over almost 3 decades, and the lessons that I've learned and the mistakes I've made. I hope and pray that none of you ever see such patients. I have seen both. This is a gentleman who could hang his clothes to dry at the rear because he had implants which were coming out. And this is a gentleman who was operated in the same hospital where I work. And there are 1, 2, 3, 4, 5, 6, 7 screws which were put in. And guess how many of them are in the pedicle? It's like the score that we lost a few years back in hockey. It is 7-0. So none of them were in the pedicle and everything collapsed. So unfortunately, we see such patients. I learned from trauma surgeons. Professor Lard was my teacher, and he always told me that if life gives you lemons, you have to make lemonade. And that's precisely what happened to me. I was already a trauma and pelvic surgeon, and he sent me off to Chennai just because a 7,500 paid kid was getting 25,000 and a free car and a lovely home to live in. And I became a spine surgeon. So that's what life did to me. These are 4 of my colleagues whom I grew up with, whom are my role models and mentors. Few of them you would know. I introduced him. This is Dr. Narayan. He's a big man in AO today. He's from Muscat. He's sitting there in Muscat and is ruling the AO International. Dr. Surya Narayan is a joint replacement surgeon from Chennai. And Shekhar Kumta is probably one of the most gifted microvascular surgeons in Hong Kong. And we are at a 1-year gap, and we were all students of that man who's showing us a finger there. I was the youngest of the 4, and I learned a lot from these guys. And I'm really grateful to them for what I have done today, including the failed backs. Well, we have a group of orthopedic spine surgeons, neurospine surgeons, and fellows who work together as a team. And we analyzed what I did in the last 30 years of my career. And we picked up only 228 cases, but that's the literature that we had, the notes that we had. And I studied them. Well, we found that there were 3 types of patients. Now, this is again, it's no classification. This is something that's coming from within. There were implant-related failed back surgery syndromes. There was surgery-related failed back surgery syndrome. And there was non-specific failed back surgery syndrome. 90, where an implant was erroneously placed. 72, where surgery was done, there was nothing wrong with the implant, or there was no implant. And 66, where your guess and my guess, we don't know why the hell they were unhappy. That's the most difficult sort of people to treat. And remember, you should have fewest of those. Well, most of the surgeries were done by us, but a few came to us and were referred to us and were added to this because we then followed them up thereafter. 1.5 years is the minimum time span that we had for these surgeries, and 25 years is the maximum that we have. And I have a lot of them who are that old as well. Well, they were symptomatic. They were uncomfortable, and they were willing for a re-intervention. That's the criteria. They should all be needing another surgery or needing something to be done. Then they come under this FBSS or failed back surgery syndrome category. This is the only part of medicine in the world which is called failed back surgery syndrome. There's no failed arthroscopic surgery syndrome. There's no failed trauma surgery syndrome. There's no failed arthroplasty surgery syndrome. For some reason, they have sort of put us in a terrible situation where we have been made to make unhappy people less unhappy. Maximum I can do is make an unhappy patient less unhappy. I can never make him as happy as you trauma guys and joint replacement guys. And especially the sports guys who even get people gold medals at Olympics. We can't do that. Any which way, let's look at the first 90 patients. They had malpositioned implants, screws, cages, spacers, etc. They had residual recurrent symptoms or fresh neurology. Well, I'll share a few. Has anybody seen this? Well, this came to me, and I am very proud that I can't find another one, but I don't know who did it, why he did it, but this man came to me with a neurology, and he came about 2-3 years after this was done. I appreciate that the cage stayed where it did for 2 to 3 years before it decided to move. Why did it move? I don't know. But it moved and he got neurology. What did I do? Well, simple. We had to just remove this cage. This is a man who came from overseas. He had this screw which was going into the root, and he had agonizing pain and had lived with it for again 1.5 years. He came across the border from our friendly neighbors, and all I had to do was just change the screw. So a lot of these are implant related things which could have been avoided on day 1. So we remove them, reposition them. Then there are some where everything looks good on day 1. As I said, it's like marriage. Fantastic. Bahut acha lag raha hai. 6 weeks down the line, the wife turns away. So the cage has looked into a different direction. And now there is neurology. This is my own patient. I have done this surgery. I went in at the end of 6 weeks when this man came for a follow-up. And I went in. What I share with you is very interesting at this stage. At this stage, I went in, I got that spacer out. I put in my number 4 Penfield retractor, which goes in. And I could feel hard bone in the interbody space. That means this was probably subclinical infection, plus the fact that the bone was healing. And I just cleaned it up and I came out. And this man progressed to heal further. May I also say that this man also is a spiritual guru. So I don't know if there's something more than meets the eye. These guys can control their blood pressure. They can even throw bone, I believe. But then he healed without any major issue and had good interbody fusion just by picking out that cage at the end of, because what I needed to do was pick out that cage, make a fresh trough and put this cage again. That was my plan. But when I took it out, I had bone through and through and feeling pretty solid, firm. Decided to do no more and he got away with that. That's the cage that I took out. So this is something where you either remove or you reposition. Now there are patients who have adverse effects during the operation. Now, please remember there are two words. There's something called an adverse event and there's something called a complication. Every adverse event does not turn out to be a complication. Every complication post-op need not have an intraoperative adverse event. A dural rent during surgery is an adverse event, need not be a complication. A post-operative sepsis may be a complication, but there may be no intraoperative event that you can attribute it to. Having said that, incidental durotomy, you've removed the pars and made the stable patient unstable, post-op surgical site SSI, discitis, interbody, adjacent segment disease, delayed or non-union, any one of your interbody or posterolaterals didn't work. Let's look at this. Well, this was a patient operated back and front, partly in Oman, partly in Mumbai, part of the surgery done in Oman, part of the surgery done in Dubai, in India, came to me 6 months after the 2 surgeries. And this was his MRI. He had this huge collection in the rear. I was not sure whether I'm dealing with pus or whether I'm dealing with the CSF. To me, it looked like pus, although he was very cold. So I thought it may be tuberculosis because that part of the world also has a lot of tuberculosis. I opened up, there was a lot of pus there. And I cleaned it all up. Fortunately, since it was about 6 months plus, I just removed the metal from the rear and I didn't touch the anterior. And he went on to heal. All the neurology, the pain, the weakness that he had developed was because of the posterior neural compression, and there was nothing anterior. So at the end of the day, if you know what your purpose is, which is decompressing the rear, you can then just do what you want and get away with it because the anterior construct by itself was reasonably strong. He was a fractured spine who had been operated this way. So that's where we are. Having said that, this is the implant which came out and I left him just with the anterior implant, and that's a post-operative MRI which showed a complete clearance. He went on to improve and he became a walker from a non-walker. I didn't take the credit. It's just that it happened. He should have got it with the surgeries, but had sepsis. Well, this is the patient who taught me the most, and it will teach you guys a lot. This is, I'm calling it L45 listhesis. Today, what would I do? Well, he's about 70 years of age when he came to me, 65 years of age when he came to me. He's a very, very well-to-do person. He's no more today, but he's very well-to-do. He's a big shot in the city of Mumbai. And he comes to me and he tells me, I've got instability. I've been told you need instrumented fusion. I was going to fly to Chennai or to Germany. Can you do it? I said, yes, of course I can do it. Younger person, more egoistic. I said, yeah, I'll do it. So what do I do? At that time, what I did, what I may do today is a little different. I went in and I did what I showed you earlier. Flexible rod. This is another type of flexible rod. These are knurled rods which can move, and a solid fusion with correction of the listhesis. My ego felt great. I have corrected this listhesis. I've done a great job. He's already 65, 70. He was stable. I should have just decomped and stabilized him in situ. But no, I did this. Felt great. I used flexible rod. It was something great. It was 2001, 2002. This was from a company called Globus at that time. They had that knurled rod which I used to use. And I was great. He did well for 7-8 years. He came back, and can that be? Can you take that out? Can that thing be taken out? Okay, then it's okay. He came back later with, great. He came back with an adjacent segment disease adjacent to the flexible rod. Why the hell did I put the flexible rod? So that he doesn't get adjacent segment disease. And he got an adjacent segment disease adjacent to the flexible rod. I said, doesn't work. Technology is useless. Removed it, put a solid rod. So now I've gone 4-5 is what we are calling it down. 3 and 2. Felt great. He felt good for another 2 years. Now we are now gone from 2010 to about 2012. Comes back in 2012. This is called proximal junctional kyphosis. There's a backing out of the implant. He's growing older. He's 72 plus. I've treated his wife. She's already on teriparatide. They can afford the best. They're on 40. Good, great. He said, Doctor, mujhe bhi wo injection de do. I said, no, sir. You're you're a tough man. You don't need teriparatide. I had not used teriparatide in men at that time. So I said, no, sir, you're good. But this is now cutting out. And then he got that disc there and he got this early cauda equina. I said, no, you will need another operation. We went ahead. What did we do next? So we are now stuck at L1. No, this is the wrong level to stop. You can't stop at thoracolumbar junction. You have to go up to D10. Great. I learned it. I went up to D10. So this is now surgery number 4. We've gone up to D10. Felt great. He was good. We felt good. Implant company felt the best. We are going up. Okay. Globus is doing well. Okay. We've gone all the way up to D10. He lives another 6 months. At the end of 6 months, he comes back and says, I'm again feeling weak. I'm falling off my feet. There's a disc which has popped out there. I had not heard of D910 discs popping out so easily, but this guy popped it out. You can see that there is a lucency there. I thought infection hoga. I went in again, cleaned it up, went up now. This time up to where? D4. Why? Because you never stop on the thoracic kyphosis. Okay, we read all that. D4. I said, great. I said, now sir, abhi iske baad kuch nahi hoega. You'll be perfectly fine. Doctor साहब आप ही का ऑपरेशन करते हो और तो सब बोलते हैं उनके पास वापस चले जाओ. Fine, that will happen. When you have such patients, nobody else is going to touch him. जाओ उनके पास वापस जाओ. So he comes back to me. Again, we have him walking and then we start having, he sends us, by that time, WhatsApp videos start coming in. He sends us how the physiotherapist is making him walk and we feel good about it. He's also feeling good about it. He's now becoming about 76, 77 years old. And he's saying now, he starts getting some cardiac problem. He says, nahi, main cardiac kara hu. Maine kaha, nahi, kara lo. Cardiologist says, no, with so much of metal, we are not doing anything to you. Stay where you are. God knows what they're up to. Anyway, he starts walking. I said, sir, abhi mera kaam khatam ho gaya. Abhi aap, by which time he's convinced that he needs teriparatide. So we start him on teriparatide. We've done his BMD. Spine obviously will give us something which is wrong. We do the hip and the forearm and the wrist. And they say, no, start teriparatide. He's very happy. He's feeling good. Start feeling younger. Wait for a little more time. And at D3-4, he develops a pathological fracture or a collapse, osteoporotic fracture at D4 with a retropulsion. And now there's a D3-4 thoracic myelopathy. I said, now I'm in big trouble. There's no place left. But then orthopedic surgeon will not stop when he can see there is cord compression at 3-4, screw is backing out. Nice. Never say die. Orthopedic surgeon never say die. I went up to D1. This time I said, sir, this time not only putting screw, I'm also putting wires. So I put screws, D1 to D1, D2, D3, went across 3-4, put in wires, sublaminar wires, also tied them to the transverse processes, everything. And then my colleagues, my partners who were in this exercise together, 2 of them, one is senior to me, one is a couple of years junior to me. He says, Ram, agar wapas aayenge to kya karenge? I said, abhi cervical spine mein jayenge upar tak. But then probably God was kind. His cardiac ailment came up again. And I had to send a small letter that may his soul rest in peace. But it happened about 6-8 months after we did this. I don't know what I would have done after this. Had he popped at C71 and he would have had an injury. But I learned a lot. Hence, when Dr. Rajiv asked me, why do you not suggest too much of surgery in lumbar canal stenosis? Why are you getting less aggressive than you were? Well, I am a little bit learning from my own mistakes. And I believe that the later we start, the lesser we do. Probably we keep them longer, happier.
Sir, but how you made him trust you so much?
I said something thrice. Counseling. I take a lot of time. I take a lot of time with my patients. And as I said, I am grateful. Sir, kahin nahi jata, sir. Wo nahi jata, sir.
Nobody would accept it.
They don't, sir. They don't. In our city, we're very good. No, I would not remove. Sir, he has instability there. He has a myelopathy. I have to decomp and stabilize. I've given him teriparatide. I've now improved his BMD. But now, if you had gone to cervical spine, as I said, this is once in a lifetime. It doesn't happen again. But I don't know what I would have done had he gone beyond that. Where? In the same thing, I would have kept doing the same thing. But primary surgery, I'll be less invasive, sir. Primary surgery, I would be less invasive. I would not try to get corrections. I would not believe that correcting that is as important. And I would have probably addressed the bone density issues earlier. I would have done a lot of things slightly differently. But as I said, but every time you get a neurological deficit, you have to respond, sir. You can't just let it go, sir. These are all neurologies. And finally, we come to that last group, which I said is the most difficult to treat, where the patient is an unhappy patient. He or she has no mechanical correctable cause on imaging. And usually the patient is out of focus, and it is the patient's relative who's very much in focus, who's very unhappy, and who's looking at you, penetrating through you, looking past you, and you're in big trouble. This is where you need communication skills. All these have to be managed without pharmacological treatment. You need advice and counseling. They need mental health consultations. You have to give it yourself. You can't send them to a psychologist or a psychiatrist. You're in big trouble if you do that. You need highly skilled consultations. And remember that you have to get them at your level. Remember that you and they have to be at the same level, neither above you nor below you. They have to be besides you. Listen to them, respect their views, open communication about all treatment choices, discuss all management options, allow patients to ask questions, ensure that they understand, be aware of their language, accept all their cultural influences, and compensate all their communications skills. If you follow these 9 rules, you can operate on the same patient 6 times, as I showed you. Well, what have I done in my revisions? Well, I've corrected them as I showed you in the type 1, category 1. I've added additional soft tissue surgeries in the other where there is, let's say, a smaller procedure to be done. And in the last, I've used pain specialists, physiatrists. I may do a little limited decompression, but may have to sort of talk to them and hold their hands forever. Well, most of these patients who have an obvious cause will go home in 4 days. Those who don't have an obvious cause will stay a little longer. And those who have no cause, despite what you do, will stay for the longest with you, inpatient and outpatient. As I said, where there's an obvious cause, second surgery will give you good results. Where there's no obvious cause, they'll give you only 56% results, whatever you may do. I have learned that type 1 gives me the best results, type 3 gives me the worst results. And we have to evaluate a risk-benefit ratio, discuss it with the patient every time, counsel with a clear intent. Please remember that revision surgery is like life. It's not just about reinventing the wheel. It needs to be a set of wheels which need to run in perfect harmony, even if the wheels are not circular. You have to think out of the box. And you must understand what Samuel Beckett said: ever tried, ever failed, no matter. Try again, fail better. Before every surgery, I say this prayer, and so must you. God grant me the serenity. It was originally quoted by Reinhold Niebuhr. God grant me the serenity to accept the things that I cannot change, courage to change the things that I can, and wisdom to know the difference. Please remember that. Say it before you operate every time. As surgeons, we can only change the anatomy and hope that the change in anatomy improves the physiology. Thank you all for a very patient hearing. We don't live in a perfect world. We have to accept our imperfections and hope and pray that things will settle down. Thank you very much.